also like to welcome the audience to San Diego. As you can see, it's always bright and sunny here. I have no financial disclosures. So why are we having this debate? It's a nice picture here of Dr. Pinto here at the NCI, who wrote our most recent guidelines on early detection for prostate cancer. And as you can see here, in the pre-biopsy setting, both biomarkers and MRIs are advocated for as an opportunity for determining whether or not a patient needs a biopsy. And as it notes here in our guidelines, it is debatable which of the newer biomarkers, alone or in combination, is best, and comparative studies are sparse. The NCCN also has guidelines that recommend either one, with a little bit stronger language in favor of the MRI. And it's overwhelming, as Dr. Pinto said, when looking at all the biomarkers that are available. This is a nice diagram that was put forth by Matt Cooperberg, looking at when to use biomarkers throughout a patient's course. And what we're going to focus on today is a little bit more towards the beginning here with 4K, ExoDx, Phi, and Select MDx. So I'm going to touch upon some older studies I'm sure you're all aware of before I go into some of the newer studies. The Stockholm trial, which was mentioned earlier by one of our speakers. PCA3 is an MRI detectable in the urine following DRE, has been shown to improve specificity for cancer over PSA. You can see here it improves area under the curve when combined with the PCPT risk calculator. But as we've also found, less consistent risk predictor for high-grade disease. 4K score looks at a bunch of derivatives of PSA, similarly has some good data in favor of it. Phi, one of the original biomarkers out there with this complex algorithm. And when the two were compared together, largely showed that they improved the area under the curve when compared to PSA alone, which is just above 50%. Select MDx, another one of the older biomarkers that some of us still use here, looking specifically at these mRNA transcripts. It's been validated in 2 multi-cohort studies in the Netherlands and has improved the negative predictive value. ExoDx, this is probably the one that I more commonly use. PCA3 ERG, which we know is really one of the most important biomarkers for prostate cancer. This is Jim McKiernan's study from, I think, 2016, which was published in JAMA Oncology, looked at ExoDx when compared to PSA, and again shows here that improves the area under the curve for patients whether or not to pursue a biopsy. And then I think some of the more exciting biomarkers that are coming in is something like My Prostate Cancer Score. So the one nice thing about My Prostate Cancer Score compared to some of the other biomarkers out there is it includes age, PSA density, family history, a lot of these patient characteristics that many of the older biomarkers do not. And they actually published a really nice study most recently in April of 2024 in a validation cohort of 151 patients had high-grade prostate cancer. The area under the curve was 0.6 for PSA, 0.66 when using a risk calculator. They looked at Phi. They also looked at, I believe, Select MDx and ExoDx, which were referenced as a 2-gene and 3-gene model. And then compared to their biomarker, found that the area under the curve was greatest with their most newest model of 0.82. At 95% sensitivity, their most newest model would have reduced unnecessary biopsies performed in the initial biopsy from a range of 15 to 30%, and for their newer model, 35 to 42%, which is quite significant for a number of patients. This is just another diagram showing that area under the curve. And then the Stockholm trial, again, referenced during one of the earlier talks. They randomized patients to their biomarker, which I didn't discuss in detail, but it basically incorporates a number of patient-specific factors, SNPs, which we didn't talk about, PSA, and then they randomized patients to MRI, and what they found that there was largely no difference between the two groups. And as Dr. Pinto mentioned, we really should be working together, and we should use both in the evaluation of patients, and there's not enough studies that have looked at both. This is a study out of UC Irvine that I really liked, where they looked at patients that got MRI, 4K, and ExoDx, and as you add those additional biomarkers to risk stratifications, patients had the best outcomes in terms of area under the curve. So in conclusion, there are numerous tests available now for the pre-biopsy decision-making process. Some biomarkers incorporate patient history as well as PSA and other derivatives. Some of these newer tests are more comprehensive and incorporate genetic markers and patient factors. And MRI and biomarkers largely should be used together and is an ideal combination in my practice for patients with a PSA between 3 and 10. Happy to answer any questions.